hereditary colon cancer, a multidisciplinary approach. I have no financial relationships with commercial entities related to this topic. What I'm going to talk about today is introduction about colon polyps, colon cancer, and then I will go over the most common hereditary colon cancer syndromes: LYNCH syndrome, familial adenomatous polyposis, MUITH syndrome, PEUTZ-JEGHERS syndrome, juvenile polyposis, sessile serrated polyposis, and P10 gene mutation. Right, let's give a quick introduction about colon polyps, and that's what we see when we do colonoscopy. We have two groups. We have neoplastic polyps, and we have non-neoplastic polyps. The neoplastic one, the most common we see is adenomatous, and adenoma itself, it's a form of dysplasia. It's a low-grade dysplasia. So the pathologist will document only if there is a high-grade dysplasia. But, as an adenoma, by itself, it's a low-grade dysplasia. It can have three different pictures in histology: tubular, tubulovillous, or villous adenoma. How it looks in the scope, it can have different, morphology. It can look with a little stalk, what we call pedunculated polyp. It can be just hanging on the wall, what we call sessile. It can be very flat. It's almost the same as the wall of the colon. Or it can be depressed as if it's an ulcer in the colon. There is a term called advanced adenoma. We don't report this in our, endoscopy. However, if you see a polyp more than 1 centimeter in size, or with high-grade dysplasia, or it has any villous component, that's by default advanced polyp. The other group of neoplastic polyps is called serrated polyps. This group has variable malignant potential. It actually looks like a hyperplastic polyp, which is a non-neoplastic polyp. But these hyperplastic polyps, if they are in the right side of the colon, large in size, or if they are rapidly growing, they can develop into sessile adenomas, and those sessile adenomas have malignant potential. What about non-neoplastic? We have hyperplastic, we have pseudopolyps, inflammatory, we have hamartomatous polyps, juvenile polyps, and those polyps, in fact, they can be part of a syndrome that can develop colorectal cancer. And I will mention later why we call it here non-neoplastic, and in the syndrome, they can form cancer. Mucosal polyps and submucosal polyps. All right, I will give a couple of slides about the sporadic colorectal cancer. So when we talk about the hereditary cancer, we have a contrast about what we're talking about. It's a major health problem in the US. Why? It is the second leading cause of death among cancer in the US. Incidence, 143,000 a year. Death is 51,000 a year. It's multifactorial, can be environment, can be genetics. Sporadic still forms a majority of our colorectal cancer patients, 70 to 80%. The genetics, or the hereditary cancer form 20 to 30%. Always remember, sporadic, there is a form of genetic within it, but it's not an actual syndrome. So that's the difference between, the sporadic one and hereditary colon cancer. The average age of diagnosis, around 69 years old. 30% located in the right colon, which is proximal to the splenic flexure. 70% in the left colon. How fast the polyps can grow into cancer? On average, within 10 years. What about people with family history, but they do not fulfill the criteria for hereditary colon cancer, which I will talk about it later. So if you have family member, or if you have a history of colorectal cancer and adenoma and first-degree relative less than the age of 60, or two first-degree relative regardless of the age, in these patients specific, you should start screening early on, not at the age of 50. You should start screening at the age of 40. The screening method is only colonoscopy. You cannot use other methods for screening. You cannot use, for example, fecal occult blood test to screen. Or you can start 10 years before the youngest case of colon cancer. Subsequently, those patients, they will need to have a colonoscopy every 5 years. That's one scenario. The other scenario, if you have a family history of colon cancer or adenoma and first-degree relative more than the age of 60 or older than the age of 60, or two second-degree relatives with colorectal cancer regardless of their age, you can start screening again early on at the age of 40, but you can use any method of screening if the patient doesn't want to do colonoscopy. And subsequently, the following procedure, either screening or surveillance, go the same as the average risk patient. It doesn't have to be every 5 years. So those are the only two situations different than the common scenario we use with colorectal cancer, which is we start screening at the age of 50, either colonoscopy or other methods of screening, and subsequently, surveillance or repeat screening according to average risk. So those are the two different scenarios. Let's move on to hereditary colon cancer syndromes. As what I mentioned earlier, these are the syndromes we're going to talk about with some few extras. So a lot of people said, if the patient is coming, most of the time he's going to come to the primary care before even see a specialist or sees a specialist. So how long or how much time does the primary care need to invest in order to get some information? So they try to come up with some quick questions and to help the primary care, or if you are seeing the patient as a first person, to take some history. Does the patient have a family history of cancer in the first or second degree relatives? Any GI cancer or pre-malignant condition may be related to GI or other cancer. Any family history of polyps in first degree relative, type of polyps, and age of diagnosis. If you ask this question quickly, it can give you an idea. Do I need to spend much time to ask about more information? Or, I don't think that the patient has any syndrome that I need to focus more about. Remember the title I put earlier, a multidisciplinary approach to hereditary colon cancer, which is, I will talk about at the end, why we call it multidisciplinary approach. Gastroenterologists cannot do it by themselves. Primary care cannot do it by themselves. Oncologists neither cannot do it by themselves. You need a teamwork on this. Lynch syndrome. It's an autosomal dominant condition. The etiology basically is a damage to several DNA mismatch repair proteins or genes and develop into mutation. These are the proteins that associated or if damaged can lead to Lynch syndrome. MLH1, MSH2, MSH6, PMS2. What is the colorectal cancer lifetime risk in those patients? With MLH1 and MSH2, 30 to 74%. You can see here a wide range. MSH6, 10 to 20%. With MSH6, it tends to have a later onset of colorectal cancer compared to MLH1 and MSH2. PMS2, 15 to 22%. And the mean age of diagnosis between 44 to 61%. Remember, in sporadic colorectal cancer, it was 69%. So this one is earlier than sporadic colorectal cancer. What about the tumor criteria? 60 to 80% in the right colon. In sporadic, it was mainly in the left colon. Metachronous lesions, it happened 16% after 10 years and 41% after 20 years. And if those patients, and this will happen if the patient treated with segmental resection, most of the time because lack of diagnosis of Lynch syndrome in these patients. Most of the time, the cancer develops from advanced adenoma. Occasionally, the adenoma is flat. They have a special criteria that the polyps tend to grow faster with Lynch syndrome compared to, sporadic colorectal cancer. It can grow within 35 months from an adenoma to a colon cancer, 35 months. What about histology? It's poorly differentiated tumors. What about survival? Surprisingly, if you will compare a stage for stage for sporadic colorectal cancer to Lynch syndrome, they have a better survival for the colorectal cancer compared to sporadic. So here what we call this syndrome or a condition, because it's not only involving the colon, it's not only have genetic predisposition, but also it has multiple other extraintestinal manifestation or extracolonic manifestation. Endometrial cancer, second most common cause of cancer in these patients, with MLH1, MSH2, 54%, with MSH6, 71%, even higher than colorectal cancer here. PMS2 is 15%. What other cancer can develop in these patients? They can develop ovarian, gastric, hepatobiliary, small bowel, transitional cell cancer, in the ureter, renal pelvis, and bladder, brain cancer, glioblastoma, I will talk about this in a specific syndrome later, and cutaneous spacious neoplasm. There are 3 different types of cancer. The data out there are controversial about if there is increased risk or not: pancreas, breast, and prostate. What about terminology? When you read the literature, there are different people using different terms. So Lynch syndrome actually was first described by Dr. Lynch in 1966 and colleagues, and they described colorectal cancer and extracolonic primary cancer in 2 extended pedigrees. And they linked this to germline mutation with MMR genes or epicam gene. There is a Lynch-like syndrome. Those are the people with microsatellite instability, and I will talk about this later, but they don't have a mutation in the gene. So in the tumor, there is a microsatellite instability, but in the blood, there is no mutation in their genes. And there is a group founded what we call hereditary non-polyposis colorectal cancer. And those group of people who fulfill the criteria for Amsterdam 1 and 2, which I will talk about, regardless of genetic mutation. So let's talk about this Amsterdam 1 and Amsterdam 2 criteria. This group, they founded the terminology of hereditary non-polyposis colorectal cancer. And this term was founded to differentiate from familial adenomatous polyposis. However, some expert out there believe that's kind of a misnomer, because those patients, many times they have the cancer or the advanced polyp, and also they have other polyps. It's not the same number as familial adenomatous polyposis, but again, many times it's not only one polyp. So in 1990, they found Amsterdam 1 criteria. Easy way to memorize it, 3, 2, 1. So you have 3 relatives with colorectal cancer. One of these relatives must be first degree relative. It has to be 2 different generations involved. And one of these 3 relatives must have colorectal cancer before the age of 50. That's Amsterdam 1. With further studies, they found that this Amsterdam 1 criteria lack of sensitivity and specificity, because there is a big group of patients not included in this criteria. So they came up with Amsterdam two criteria in 1999. And the only difference they included that those patients, those three relatives, they are not necessarily must have colorectal cancer, but it can include hereditary non-polyposis colorectal cancer associated cancer, which means other extracolonic cancer, like cancer at that time in 1999, they put cancer endometrium, small intestine, ureter, renal, pelvis. But later on, a lot of experts included other cancer, which is ovary, stomach, hepatobiliary, and brain, which all can be associated with LYNCH or hereditary non-polyposis colorectal cancer. What about revised Bethesda criteria? This criteria established to identify the patients who needs microsatellite instability, testing, or immunohistochemistry testing, and genetic testing. So it's mainly was going for the line of Lynch syndrome rather than hereditary non-polyposis colorectal cancer. I don't expect anyone to remember all this, but criteria include colorectal cancer younger than the age of 50, synchronous or metensynchronous colorectal cancer or Lynch syndrome-associated cancer, colorectal cancer with high MSI pathologic feature younger than the age of 60, first-degree relative with colorectal cancer or Lynch syndrome-associated cancer, patient with colorectal cancer, or colorectal cancer with Lynch syndrome associated at any age in two first-degree relatives. Again, you're not supposed to remember all this. If you are going in this line in your patient, you always can look it up and see where your patient can fill in this criteria. So there are a few syndromes I will mention here. So when you see these patients, you don't think, why this patient does not fit the whole criteria. There is familial colorectal cancer type X. And those patients, they fulfill Amsterdam 1 criteria. But when you test the gene, they don't have any microsatellite instability. So we call it familial colorectal cancer type X. The onset of colorectal cancer is later in age. Lifetime risk is lower compared to people with Lynch syndrome. And they rarely have any extracolonic cancer. Actually, they fall into the same risk as general population. So these are a couple of syndromes that hereditary colorectal cancer can be associated with brain tumors. Turcot syndrome, which is basically Lynch syndrome with brain tumor, mainly glioblastoma. There is another syndrome associated with familial adenomatous polyposis. I added here so we can memorize it. It used to be called Turcot syndrome, but now a lot of people call it Krehl syndrome. Dr. Krehl described this case in the military very back in the days. At that time, the military journals were not allowed to be published to the general population. But people, when they look backward in the records, they found Dr. Krehl described this syndrome. That's why they went back and called it Krehl syndrome. It's basically familial adenomatous polyposis with brain tumor, but mainly medulloblastoma, not glioblastoma. MUIR-TORRE variation or syndrome. That's patient with Lynch syndrome associated with spacious skin neoplasm. It happened more frequently with MSH2 mutation, and the microsatellite instability can be found in the colon cancer or even in the skin neoplasm. It doesn't have to be in the colon cancer only. Constitutional mismatch repair deficiency syndrome. Those are families with biallelic mutation for the MMR genes. But many times they have café au lait spots in their skin. And the main character in this group is that they will have an early onset childhood or teenage years colon cancer. So the cancer is very early age or very early in life when it's associated with Lynch syndrome. All right, so let's go back to Lynch and how we screen those patients. You have a patient with colon cancer or extracolonic neoplasm. You may think it could be related to one of these syndromes. What an easy way you can screen those patients. Castrinos and colleague came up with a questionnaire. It has 3 questions, straightforward. Does the patient, or you ask the patient if he has any first-degree relative with colorectal cancer or any Lynch syndrome-associated cancer. Remember, we talked about endometrial, we talked about gastric, we talked about ovarian, and all these other cancers. So is there any family member with any type of cancer, especially first-degree relative? Does the patient himself have a colorectal cancer or colon polyps before the age of 50? That's question number 2. Does the patient have 3 or more relatives with a history of colon or rectal cancer? And they looked into statistics when they have all these questions answered. If the patient answers these questions with yes, all of the 3 questions, you have 77% high-risk individual. And actually 95% of these patients, they will carry a certain mutation, even if they don't have the phenotype. So when you test them, they will carry the mutation, but they may not have the phenotype for Lynch syndrome. And if the patient will answer yes to any of these questions, he should go for genetic evaluation, or that's what they did in their study. Now, away from this questionnaire, if you have a patient with colon cancer and you think he fulfills Lynch criteria, there are a lot of calculators developed online, and the same as when we do MELD score for our liver cirrhosis and these type of patient. There are 3 scores out there: MMR Predict, MMR Pro, or PREM. And MMR Predict has the highest specificity, 90%. PREM has the highest sensitivity, 90%. It's helpful, but some expert out there, they believe they kind of over-calculate the numbers. But I think when it comes to a patient, you want to see where the patient fall in the category of hereditary colon cancer. You always look into more than one aspect in his history, physical, and subsequent genetic testing. So what we do for these patients, when we find a colon cancer, we normally test the tumor for MSI and immunohistochemistry. And if we see instability or lack of protein in immunohistochemistry, we refer the patient for genetic testing and we check for those genes. I will have an algorithm to make it more easy how we walk ourselves, or how genetic people actually look into this testing. So what is the sensitivity and specificity of MSI and immunohistochemistry? If you will check the tumor tissue for microsatellite instability and it come back unstable, it has sensitivity of 85% and a specificity of 90%. It's very good for Lynch diagnosis. If you have immunohistochemistry, lack of expression of MMR genes, it has a sensitivity of 83% and a specificity of 85%. Always remember the specificity of MSI and immunohistochemistry decrease with age because they develop a lot of other genetic mutation. So some experts, they suggest if the patient older than the age of 70, it may not be accurate to check for those. So in the new guidelines that it came this year, and also about Lynch from last year, They are trying to come up with universal testing or universal algorithms that all of us, we can look at and we can follow. So let's start here. It looks busy, but it's not really difficult. Patient, you scope the patient, he has colorectal cancer. You take a biopsy. You tell your pathologist, I want you to check for MSI and immunohistochemistry testing. If the MSI stable or normal, no further testing. If the MSI high, and if you haven't done immunohistochemistry, you do so. If there is loss of MLH1 and PMS2, you check for BRAF mutation or promoter hypomethylation. BRAF cannot happen in Lynch syndrome. So if the patient comes with BRAF gene positive or present, this patient does not have Lynch. So that's again out of the picture if he has BRAF gene. It does not happen with Lynch syndrome. If he has loss of mismatch repair protein, not MLH1 or PMS2, you go for genetic counseling. And again, in this group, if BRAF is negative or absent, you go for genetic counseling. So that's the algorithms they are trying to come up. And always remember, as the time goes, a lot of discovery happen in this entity. And they kind of fine-tune the criteria, how we look into this. But genetic counseling now is playing a major role in kind of better description of these patients or identification. Now, you diagnose your patient with Lynch syndrome or carrier of Lynch syndrome, how we go and further manage those patients. For screening, they recommend to start history and physical and family member who are carriers at the age of 20, 25. Colorectal cancer, you look in the first degree relative. Colonoscopy is the only screening method, so you cannot use other methods. You start at the age of 20, 25, or 2 to 5 years before the end stage of diagnosis. And actually, the 2 to 5 years is variable between some organization, but that's the range that they look into it. And then further screening every 1 to 2 years. For the patient who have positive mutation, they need to have annual colonoscopy. Okay? So some patients are carrier, but some patients, they have a mutation or family member, and some patients, they are carries a mutation of the genes. For patient with MSH6, PMS2, some experts suggest later screening may be justified based on they can develop later onset of colorectal cancer. However, that's too much details, and sometimes a lot of experts, they will go with early screening. What about endometrial cancer? It can start, or the patient can develop cancer between 48 and 62 years of age. If you're going to start screening, you start at the age of 30, 35 years old with pelvic exam and endometrial sampling annually. For the ovarian cancer, you start with transvaginal ultrasound at the same age. That's expert opinion. Based on observational studies, a lot of experts recommend that you should offer these patients hysterectomy and bilateral oophorectomy once they completed or they finished the childbearing period, or at the age of 40, based on the data that cancer can develop at the age of 48. What about gastric cancer? 8.5% in men, 5.3% in women. Suggestion to start EGD, 30, 35 years old, and every 2 to 3 years. If those patients will have Helicobacter pylori positive, they must be treated. And again, that's an expert opinion. For urinary cancer, they can develop, as what I mentioned earlier, transitional cell carcinoma. they recommend to do UA cytology. And actually, again, that's an expert opinion. For the pancreas, prostate, and breast cancer, again, the data are controversial if the risk is increased or not, so routine screening is not recommended. All right, so now you're screening your patient. One of your patients developed colorectal cancer. So how we treat this patient? With sporadic colon cancer, we do segmental resection. We do right hemicolectomy, left hemicolectomy, or if it's localized to one area, surgeon can perform segmental resection. Here in those patients, we have to do colectomy, or suggest for the patient, or recommend for the patient to have colectomy. There are people can do LU-rectal anastomosis, and if you will do so, based on the data that most of the tumor happen in the right colon, you still have to do surveillance of the rectum. And some experts suggest less extensive surgery if the patient is old in age or if they have anorectal sphincter dysfunction. But again, you need to do surveillance of the rectum in those patients if you will do LU-rectal, not LU-anal anastomosis. Let's switch gears here to polyposis syndromes. Familial adenomatous polyposis. This is the most common. It's autosomal dominant. It has a mutation in the APC gene. It has hundreds of polyps. So if you will examine the colon, you will see hundreds throughout the colon. Colon cancer inevitable in those patients, and on average, it develops around the age of 39. Again, it has extracolonic manifestation. Here is one of the interesting information. 1/3 of these patients will not have any family history of familial adenomatous polyposis, or FAB. So 1/3 of those patients, they are not going to have any family history. So what about extracolonic manifestation? Cancer can be second most common duodenal or ampullary, hepatoblastoma, thyroid, mainly papillary cancer, angiofibroma. In the eye, they can develop a lesion called CHRPE, congenital hypertrophy of retinal pigment epithelium. They can develop bone osteoma. They can develop fibroma, lipoma, or epidermoid cyst in the skin. That's how CHRPE lesion look in the retina. So most likely this patient will be referred to you from your ophthalmologist colleagues. That's how a bone osteoma will develop behind the ear or in the forehead. So how we manage those patients? In the first-degree relative, if you have a patient who have the phenotype, for FAB, you need to test this patient first for the gene. And once you detect the gene mutation, you can test other family members. And that's the way how we do it, because if you don't know the mutation, sometimes it's hard to test family members. So if patients are carriers, but you don't know the actual gene, unknown mutation, so in those patients, you go with the screening methods that I will talk about. If the mutation is known and you test the first-degree relative and they don't have this mutation, you don't have to screen them unless they are symptomatic. If the patient has FAB-like extracolonic manifestation, or again, presence of symptoms should always direct you toward the screening of these patients. So what we do with screening? We do annual colonoscopy or sigmoidoscopy. We start at the age of 10 to 12 years old, unless the patient are symptomatic earlier than this. We have a kid in our practice who was scoped at the age of 7 and found to have polyps. What you do for surveillance? For surveillance, you need to do colonoscopy, and every year. You can actually start by doing sigmoidoscopy But if you find polyps, you need to do colonoscopy, because many times you can miss attenuated familial polyposis, which I will talk about it in a minute. For the duodenum and the ampulla, we do endoscopy with a EGD scope and the side view scope to look to the duodenum and the ampulla. We start at the age of 25 to 30 years old, and then every 6 months to 40 years, based on Spiegelman criteria, which I'm not going to talk about it here for the sake of time. But there is a criteria. We justify when we need to see the patient next for repeat EGD and side view scope. And that's based on the number of polyps, the size, the histology, and other criteria. For the pancreas, we can use an EOS or imaging every 1 to 2 years, starting around the same age. For the thyroid, annual ultrasound. For patients that we worry that they may have hepatoblastoma, especially if mutation is known in the family, we start at the age of 6 months, and every liver ultrasound, alpha-fetoprotein every 6 months, till the age of 7 years old. After 7 years old, the risk of hepatoblastoma become very small. What about treatment? Here, I mentioned in Lynch syndrome, we do LU rectal anastomosis if they cannot have, LU anal or pull through. But here, with FAB, we need to be very aggressive, even more aggressive than Lynch, because they can develop universal polyps throughout the colon, even in the rectum, even at the anastomotic site. So if the patient is young in age, our first choice is LU anal pull through, which is a multi-stage surgery that the surgeon has to do. The problem with this surgery, it can decrease fertility in men and women. So you always have to sit down and talk to the patient about the surgery and the consequences, before you proceed with the surgery. Other option, you can do total colectomy with ileostomy, or you can do LU rectal anastomosis. And all three options, if there is still a pouch or a remaining rectum, this need to be screened every year. And that's what I mentioned here. What about genetic testing? I believe I mentioned this briefly. You need to test the affected member first to identify the mutation. Once you know the mutation, you can screen the family member for the other, for the same mutation and see if they are positive or negative. What about attenuated familial adenomatous polyposis? They have polyps less than 100. Polyps are mainly in the right side of the colon. When you look to the APC gene, those patients with attenuated FAB, they have damage to the 5 and 3' ends of the gene. As you go to the center of the gene, the more damage in the center, the more aggressive is the disease, and more aggressive is the tumor and extracolonic tumors. Those patients, they develop colorectal cancer around a decade later compared to familial adenomatous polyposis. You cannot screen those patients with sigmoidoscopy because most of the tumor develop in the right colon. So they need annual colonoscopy. Some patients can be managed with just colonoscopy, removal of the polyps. But once these polyps have high-grade dysplasia or too large to be removed, you need to, recommend colectomy and let the surgeon to see those patients. What about MAP or MUTYH associated polyposis? It's autosomal recessive, one of the few autosomal recessive cases I'm talking about. The injury mainly base excision repair gene, and the risk of colorectal cancer is around 43% at the age of 60. sorry, the risk of colorectal cancer, 43% at the age of 60. And normally the onset happens around 40 years old. The management of these cases, we manage it like attenuated familial adenomatous polyposis with endoscopy. If you can remove the polyps, well and good. Once they start to be large in size, more dysplasia, or too big, you need to recommend colectomy. That's to make it simple how we can remember this. It looks like familial adenomatous polyposis. It has colon polyps. Gastric polyps are present. They can develop duodenal adenoma or adenocarcinoma. It's different from familial adenomatous polyposis that they can develop some other extracolonic tumors like breast, ovary, urinary, and skin. Though it's also different, they cannot develop osteoma, thyroid cancer, CHRPE lesion, or desmoid tumors. There is a new syndrome that was diagnosed not long ago. It's called polymerase proofreading associated polyposis. It has oligopolyposis, so it doesn't have hundreds of polyps like familial adenomatous polyposis, but early onset of colorectal cancer. It is autosomal dominant. The genetic part is still evolving, but the genes that they identify so far, POL, which is a known one, and POLD1, which is a new one. We don't have any consensus how to manage these patients, but again, those patients need a close endoscopic screening and surveillance. Let's move on to PEUTZ-JEGHERS syndrome. That's one of the hamartomatous polyposis syndrome. It's autosomal dominant. They have a characteristic mucocutaneous pigmentation on the skin, which happen almost in 95% of the patient. The gene mutation is in STK11 and LKB1. That's the genes that normally develop mutation in these cases. That's how hamartomatous polyp will look under the microscope. It will look like a tree of a smooth muscle lined with colonic mucosa. Once we see this tree of smooth muscle, that's called hamartomatous polyp. And that's mucocutaneous pigmentation. It can be in the lips, can be in the buccal mucosa, can be in the hands, feet, can be in a lot of other areas in the skin. The polyps distribution, it's actually more common in the small intestine. Second common place is colon, third common place is the stomach. One of the interesting things that may happen, that those kids or teenagers can develop small bowel intussusception, and their first presentation coming with acute abdomen with small bowel intussusception. So if you have someone telling you in my teenage time or still young in age and you were consulted for small bowel intussusception, you need to look into the pathology and make sure they don't have hamartomatous polyp kind of stuck there and caused or led to the intussusception. What about the neoplasm? The lifetime risk of neoplasm is 93%. That's very high. So this patient basically going to develop cancer at any point. And sadly, I had a patient 2 weeks ago in my office, came and his daughter diagnosed with familial adenomatous polyposis. And his statement, he said, I'm waiting when she's going to develop a type of cancer. So that's the mentality that a lot of these patients and their families, they live with. So the lifetime incidence is 93%. So it's important for us to find out those patients. However, for every individual cancer, the lifetime risk for breast cancer is 54%, colorectal cancer 39%, pancreas 36%, stomach 29%, ovary 21%, lung is 15%. Those patients can develop some rare tumors. They can develop Sertoli cell tumors in men In women, they can develop cyst adenoma, 6-core tumors, adenocarcinoma of the uterine cervix, or granulosa cell tumors. So how we screen those patients? PEUTZ-JEGHERS is the most aggressive screening system we have, even more aggressive than FAB. And we start at birth with history and physical, testicular exam, and blood work. At the age of 8, they start having EGD, colonoscopy, and small bowel imaging. And if they have polyps, you go every 3 years. If they don't have polyps, you readdress the issue at the age of 18, or if they are symptomatic. And you do the same, EGD, colonoscopy, small bowel imaging. But at the age of 18, you start every 3 years, regardless if they have polyps or not. And also you start breast examination every 6 months. For the small bowel imaging, we can use CT enterography, we can use video capsule in those patients. At the age of 25, you start doing pelvic exam, pap smear every 1 year. And you can do pancreas ultrasound every 1 to 2 years and mammogram. For the breast, in addition to mammogram, you can do the MRI. For the ovary, you can do transvaginal ultrasound and CA-125 every year. Remember, no one can memorize all this. The key is to identify those patients, and once you have the patient in the right direction, you can follow the algorithm that people have out there with not only yourself, but through a teamwork. How we treat, we remove colon polyps, gastric polyps, small intestine polyps, we can remove with endoscopy. Now we have a single and double balloon enteroscopy, which one of the way how we can remove these polyps. In the past, they used to recommend in the small bowel, you remove the polyp if it's 15 millimeter in size, or if it's rapidly growing. But again, if you are doing balloon enteroscopy and you find the polyp, you can remove it. Why do you leave it there? Juvenile polyposis. It's autosomal dominant. It's 2 genes affected, SMAD4, MADH4, which is the same gene, BMPR1A, and those genes only present 60% of the cases. So this means 40% we have a known gene. In these patients, 75% they will have a family history of juvenile polyposis. 25% they are brand new. They have no family history. They will present with colon polyps. They have a higher incidence of colorectal cancer, 39%, other neoplasm, stomach, duodenum, and pancreas. That's how, juvenile polyp look under the microscope. It has dilated cysts with a lot of mucin fill inside the cyst, and the lamina propria is kind of inflamed. That's typical for a juvenile polyp. So for hamartomatous polyps and juvenile polyps, they are actually, as what I said earlier, non-neoplastic polyps. However, once they are part of these genetic syndrome, they have potential changes with either rapidly growing in size or adenomatous changes that leads to cancer. So when they are part of these syndromes, they have a different mechanism of growth that leads to colon cancer. So what is the diagnostic criteria? You either have 5 juvenile polyps in the colon, or juvenile polyps anywhere in the GI tract other than the colon, or any number of juvenile polyps in a patient with family history of juvenile polyposis. We start colonoscopy at the age of 12, and then every 1 to 3 years. EGD is the same timing, every 1 to 3 years. Patients with SMAD4 mutation, and they have a gene damage, they have higher incidence of hereditary hemorrhagic telangiectasia. Sessile polyposis syndrome. That's a syndrome start to develop over the last 5 to 10 years, and we are kind of getting more understanding as the time goes about this syndrome. A lot of these polyps in the past, pathologists they used to call it hyperplastic polyps, but now we are seeing that those polyps, once they develop in the right side of the colon, and many times they are flat, they have a higher malignant potential compared to just a regular hyperplastic polyp. They can be just as a sessile polyps, but also they can be part of a syndrome called sessile polyposis syndrome. What is the criteria of this? Any one of the three. If you have 5 polyps, 2 of these polyps more than 10 millimeter in the proximal to the sigmoid colon. If you have 20 of serrated polyps anywhere in the colon, or if you have serrated polyps, any number of size proximal to the sigmoid colon in a patient with a first-degree relative with sessile polyposis syndrome. How we manage those patients? We do colonoscopy every 1 to 3 years. In the last guidelines, they recommend actually annually, but some subsequent guidelines, they say you can do 1 to 3 depending on the number of polyps that they will found or you will find in the colonoscopy. And again, that's for the patient with sessile polyposis syndrome, not just a regular sessile polyp. What about first-degree relatives? What you do? You start colonoscopy at the age of 40 or 10 years younger than the age of diagnosis. Multiple studies actually revealed links between, sessile polyposis syndrome and smoking. And a lot of experts suggest smoking cessation in these patients. The last thing last few slides I will talk about is PTEN gene mutation. It's 10-phosphate and tensin homolog gene. They have 2 syndromes. The first one is Cowden syndrome, which has a lot of colon polyps. These polyps can be hamartomatous, ganglio, neuromas, present in 95% of the patient. They can have stomach, small intestine polyps. They can have other extracolonic neoplasm, breast, thyroid, renal, cerebellar gangliocytoma, or colorectal cancer. The characteristic of Cowden syndrome is trichomoma, and that's the characteristic of these patients. And that's a picture of trichomoma, which is kind of skin color warty lesions on the lips. The other syndrome of PTEN gene mutation is Benyon-Raleigh-Ruvalcaba syndrome, and it has 3 characteristics: young men, macrocephaly, and penile pigmentation. There are a few cases out there, sometimes some patient associated with autism, but those are the 3 characteristics: young men, macrocephaly, and benign pigmentation. Other characteristics can be present as well. Last slide. Hereditary mixed polyposis syndrome. That's again one of the newer syndrome, more described in Ashkenazi Jewish. The genes that they know so far, and again it's evolving, CRAC1 or GREM1 genes, and management similar to FAB. So when I mentioned earlier in my first slide, the multidisciplinary approach, no specialty can manage those patients by their own. You need your primary care to detect those patients early before they develop symptoms, and they come either to the oncologist with cancer, or to us as gastroenterologists with blood-brain rectum, or however we may be the first specialty to see this patient as well. So you need a primary care, you need a gastroenterologist, you need an oncologist, you need genetic counseling, you need a surgeon who understands how aggressive he needs to be on those patients. And more importantly, you need a psychiatrist or a psychologist. A lot of these patients, they are frustrated. They are waiting for their first cancer, and they can be depressed. So you need a psychiatrist not only for the patient, but also for the family member, to walk them through this journey of, busy schedule, multiple procedures, genetic testing, and multiple visits to, many physicians. And these are the references, and happy holidays. I'll be more than happy to take any questions.
What you're saying, Dr. Boktor, is that a lot of people that are a lot younger can develop colon cancers. And these are the ones that we tend to find sneak up on us. And we in our department have just recently had a 14-year-old with colon cancer. So when you're out there and you're thinking, gosh, this patient with some rectal bleeding is too young to have a cancer. They're not. So think about it.
Yeah, if you have a symptomatic patient, do not take it lightly. Take a good history from the patient. Also, the other take-home point, anyone with a colon cancer younger than the age of 70, you need to test the tumor for microsatellite instability and immunohistochemistry. You do not say, oh, he is 60, likely sporadic colon cancer. I do not need to test the tissue, because you can make a difference, not only in his family member, but even in the management of this patient. If this patient has positive or unstable for microsatellite, he cannot just get a segmental resection. He needs subtotal colectomy or total colectomy with ileorectal anastomosis. So you need to be more aggressive with those patients.
So Dr. Torrhe, when you had 14-year-olds, did they find any hereditary component?
I don't know yet whether they did.
I almost wonder, could that be sporadic at 14?
Yeah.
It was stage 4 cancer,
Yeah,
surprisingly, and I think she's still going through.
She's still going through the workup. She was not long ago diagnosed, 2 to 3 weeks, I believe 3 to 4 weeks ago.
The one I'm thinking of that Dr. Morrison's was
Yeah, that's
2
the
months
same
ago.
one,
That was
yeah,
2
that's the
months
same
ago.
one we
That
saw.
was 2 months ago, and ended up in the ICU.
Oh, okay.
No, this patient was at Willis Knight, I believe.
And here.
And she came here.
This is this was a
Developed a 5-FU toxin, apparently, and ended up in the ICU. Injection 20%. That was a couple of months ago.
The unfortunate thing with this kid was that, he had symptoms for more than a year, and I don't know, he was taken to a PCP or something, and they thought he might have hemorrhoid or IBD or something, and never was referred to a GI doctor.
Yeah, that was the last I heard, though, was a couple of months ago, and I was wondering, because you almost can't imagine a 14-year-old not having...
Stage 4, yeah.
Yeah, not having some hereditary component, something.
Yeah, a couple of years ago, I had a patient with known gene mutation in the family with familial adenomatous polyposis, and no one bothered to screen. And she came with colon full of polyps.
As a historic sideline from this stuff from an old physician, is all of this is so different than it was when I was in your position, at your age and your development for medicine. We were taught that 90% of the colon cancers occurred within 25% of the, or 25 centimeters of the anus. Can you imagine that? And now we know that they're all over on the right side. But we had no way of getting there. We had no way of looking at them. The only thing we had were barium studies. I remember sitting in a meeting when the pathologist got up and started describing the genetic mutations that they were seeing in these right-sided cancers that were occurring in between the times that they should with colonoscopy screening follow-ups. And all of this has developed in the last few years, all within my lifetime. So heaven knows what you guys are going to know about colon cancers, breast cancers, lung cancers, all of these things in your lifetimes. You'll look back on this in a few years and say, gosh, we didn't really know a whole lot.